HealthEd is Australia's leading provider of quality clinical education for doctors and other healthcare professionals. This episode has been made available on Spotify and Apple Podcasts. For free access to the full library of podcasts and to claim CPD for listening, visit healthed.com.au or download the HealthEd app.
Today my guests are Dr. Jasneek Chawla and Dr. Sarah Blunden, and we're going to be talking about sleep medication in children, and more specifically about the role of melatonin in treatment of children. Dr. Jasneek Chawla, who likes to be called Jazz, is a paediatric respiratory and sleep medicine specialist at the Queensland Children's Hospital, Brisbane, and she's the Associate Professor with the Health Research Centre, University of Queensland. Dr. Chawla is actively involved in clinical research and was awarded a Queensland Advancing Clinical Research Fellowship in 2020 towards her PhD, in which she evaluated the impact of sleep interventions on outcomes in children with Down syndrome. Her areas of interest include sleep in children with disability, the relationship between sleep and long-term cognitive and behavioural outcomes, and the development of additional tools for the diagnosis and management of paediatric sleep-disordered breathing. Dr. Chawla is a board director for the Australasian Sleep Association, as well as chair of the Educational Committee and deputy chair of the Conference Organising Committee. My other guest is Dr. Sarah Blunden. Sarah is a clinical psychologist and is the head of the paediatric sleep research at the new Adelaide campus of Central Queensland University, Australia. Sarah founded and directs the Paediatric Sleep Clinic in Adelaide, which treats children with sleep problems. She also oversees the Australasian Centre for Education in Sleep, which aims to increase sleep education in the community. Sarah has published widely on paediatric sleep disorders and has presented at both national and international sleep and psychology conferences. Hello, Jazz and Sarah, and welcome to today's HealthEd Children's Health Podcast.
Good morning and lovely to be here. Thank you.
Hi, great to be here.
Hi, Jazz. Now, I know we're going to be talking about melatonin and sleep medications in children, but before we do that, can I ask each of you what got you interested in paediatric sleep disorders? Maybe Jazz first.
Sure. Well, I trained in the UK as a respiratory and sleep physician, but did predominantly respiratory medicine during my training in the UK, and then came over to Australia to do a sleep fellowship in Brisbane. And really that's where my interest kind of was piqued. I found that I was really passionate about sleep medicine, and I think that there's so much more to it than just the breathing stuff that we often focus on. I sort of delved further and further into sleep medicine, and now have a real interest in sleep, particularly in children with neurodisability, but see a wide range of children with sleep problems in my clinic day to day.
And Sarah, how about you? What got you interested?
Well, I'm a clinical psychologist, and during my training for psychology, my honours and master's degrees were taken in working with children in the area of sleep disordered breathing. So that's where my interest started sparking. And as I came through as a psychologist, I'm very interested in the development of children and how sleep can impact development, performance, growth, and mental health, obviously. So I've been doing that for the last 15 years about how sleep impacts children's and families' development and functioning. So I also run my own clinic, and so I see at the hardcore face people who come in with children who don't sleep. So unlike Jazz, I come from the psychological perspective more so, having done a PhD in the hospital, so I can screen for the physical stuff. But brilliant. I think that we make a good kind of combination between the sleep respiratory and the psychology.
I was just going to say that I get the chance to pick both brains in the podcast. Absolutely perfect. Sarah, how common are sleep disorders in children, and how do most kids present to someone like you?
40% of children and families have a child that doesn't sleep well, meaning they don't have optimal quantity for what they would need to be able to function okay, or their quality is poor. My job is for people to come in and see me, and I work out which part of those things is the problem and what are the contributing factors. So for me, that would be either physiological, and that I would pick up screening for snoring and or anything physiological. And then psychological and environmental and behavioural is what I can deal with. What psychological things are going on? Is the family stressed? Is the child anxious? Is there an environmental contributor? Are there screens being used? That kind of environmental and behavioural stuff. I have 2 psychologists that work for me. We work full-time every day, and we have done it for the last 15 years. It's a very common problem.
Yeah, I would agree. And, my clinics are at the Children's Hospital in Brisbane, and probably quite a different spectrum of people that come to me. We see children who've often gone through general paediatricians, sometimes straight from the GP, but often the children I see have other underlying medical conditions, and they come with sleep problems that are sort of coexisting to those. So, around 80% of children with neurodisability will have a sleep disorder of some sort. Often the reason for referral to my clinic is for snoring and evaluation of obstructive sleep apnea or sleep disordered breathing. But very commonly, we see these children have as well significant non-respiratory sleep problems that require intervention or require treatment. And we would work closely with people like Sarah, referring to psychology to help us support these children, as well as undertaking some of that management and support ourselves.
Jas, I think many of our listeners are going to be familiar with the use of melatonin in adults, but can you remind us of what it is and how it works?
Sure. So melatonin is a hormone that we all secrete. It comes from the pineal gland in the brain. People sometimes refer to it as the darkness hormone, and it's essentially synthesized and secreted during darkness. So that's kind of where that name comes from. And its production is inhibited by light. So we generally tend to see low levels in the day and high levels at night. And its main important role from a sleep perspective is to synchronize your light and dark cycles and regulate your sleep-wake cycle. And the timing of when you produce melatonin is affected by lots of different things, but certainly light is a big factor. And it does have some other effects as well. So there's some thoughts that melatonin is also an antioxidant. It has some immune modulating effects, but really from our perspective in the sleep world, it's the key hormone that governs your sort of sleep-wake cycle.
Sarah, can I ask you, what are the indications for the use of melatonin in children?
That's a very good question. The TGA in Australia has indications for use in melatonin for children who have neurodevelopmental disorders, most particularly, and those that are TGA recommended, are the autism spectrum and Smith-Magenis syndrome. So that's a very small window of children who have recommended melatonin use. The use of melatonin is very common in other neurodevelopmental disorders such as ADHD. I see a lot of those kids that come into me, and I see probably 80% of my clientele would be children on the spectrum, and so looking for sleep assistance on top of their complex conditions that they have. So melatonin is being used in a lot of other situations other than TGA recommendations.
This episode is one of hundreds of informative and free clinical podcasts from Health Ed. Access the entire library through the Health Ed app for healthcare professionals, which you can download today from the App Store.
Jas, that brings me neatly to my next question. Do we have any evidence for the safety of melatonin in kids, and maybe for how long it can safely be used?
Yeah, again, good questions. Look, the evidence is there to support use in specific populations mainly. The honest answer is that we need more evidence and we need robust trials. The biggest group in which this has been shown to be effective is, as Sarah said, the children with ADHD, ASD, developmental disabilities. And even that, we sort of broaden that out to use in children with neurodevelopmental conditions. But the evidence is there for those groups. In terms of how long you can use it for, I guess we don't know, to be honest, the long-term negative effects of using melatonin. Certainly in the short term, it seems to be relatively well tolerated. There are sometimes a few side effects that you see with starting it, things like headaches, some GI upset. But more often than not, children will tolerate the medication quite well. There has been some concern from small studies that has not been replicated again, which has suggested that it could affect puberty and reproductive function. And again, some concern about its use in children with epilepsy or those with seizures. But these really haven't been further investigated in bigger, robust trials. So I think in terms of how long you can use melatonin for, the reality is we don't really know.
And Sarah, do the effects of melatonin wear off over time in kids?
Similar to what Jazz was just saying, we don't know the answer to that question because we haven't got long-term data. Mm-hmm. I think from memory, I'm on the International Paediatric Sleep Association Melatonin Task Force, and from memory, the longest long-term study, if you like, is 2 years, where we followed children up on 2 years. And these are children with neurodevelopmental disorders. So we don't know if children are on for more than 2 years what the effects might be. It does certainly look like the side effects and the efficacy, the side effects are generally manageable and the efficacy looks like it's pretty good. So it would be great to get some better data about whether or not that is the case, about long-term use of melatonin could be safe for children. The worry, of course, is that it is a hormone, and we need to be wary of the fact that as a child grows, their hormonal balance changes, and what does that mean over time? We don't know the answer to that question.
Jazz, are there any pearls of wisdom that you'd like to give us regarding the prescription of melatonin in kids?
Yeah, look, I mean, I think this is a really important area, and I think the first thing I would say is that, you know, prescribing melatonin should really involve having tried other things first. So certainly our practices is that we would really want to know what else the families have been doing. You know, we talk about sleep hygiene or good sleep patterns and good sleep behaviors, and I think that's a really important focus before you even consider medication. You know, there's no point in prescribing melatonin to a child if they are not doing the other things, like having a set bedtime, having a set wake time, you know, trying to minimize light exposure at bedtime. Equally for adolescents, you know, really thinking about the technology use and what they're doing through the course of the night is really important. So I think there's a real important amount of information that you need to gather during your history and things you need to target before you actually go to thinking about prescribing melatonin. Some studies and some clinics will actually ensure that children keep a sleep diary for several weeks before they would actually prescribe melatonin. So I think that's an important thing to say. And I think the other thing is to say that, you know, when you do prescribe melatonin, you need to remember that its main action that we're using it for is to help with sleep onset latency. So there is a tendency to think that melatonin will fix all aspects of sleep, and it certainly isn't the fix-all drug. Its best action is for sleep onset. It does have some other uses that we use in our clinics for children who have what we call phase shift or phase delay. But in the majority of cases, you're really using it to get sleep onset to be better. So I think, again, that's important. I think the dosage, I'd start low, and, you know, there is limited evidence that going above the sort of 3 to 6 milligrams is of any benefit. So I would stick to lower doses. And I think it's important to think about, you know, if you're not seeing improvement with use of melatonin, then these children are children that probably need to be under the care of someone who's specializing in sleep health and is actually practicing sleep medicine on a regular basis, whether that's a psychologist or whether that's someone like me in a sleep medicine clinic. It doesn't matter. It's just got to be someone who's doing it all the time.
Sarah, is anything you'd like to add to that?
Yes, I would. And I really take Jazz's last point there, that we really are keen for parents who are prescribed melatonin to be followed by a health professional. It's imperative that happen. There is a growing tendency for melatonin to be sourced online from countries where it is not as regulated as it is in Australia. Mm-hmm. I am presented often with families who are completely exhausted, with children who have complex needs and or behavioural sleep problems that keep the entire family awake. And these people are really struggling. So as the GP is the first point of call, and therefore the person who has the capacity to refer on to a specialist, as Jazz was saying, or have a conversation with the family about what sleep patterns are happening, It's important that melatonin be followed by a professional, a GP at the very least, paediatrician, sleep physician, psychologist. It's a bit of a Wild West situation where melatonin is sourced online and then brought into the country and given to children without due diligence and following them up. So that's really my pearl of wisdom is we understand that sleep loss for parents and families is exhausting. There are interventions that are successful. And like in the adult literature, the combination of medication for children plus behavioural sleep interventions, the things that I do most particularly, that combination is very successful, and then hopefully we can wean off the medication at a later date. So that's my pearl of wisdom.
Thank you very much, Sarah. Maybe a question to both of you. Now, there's going to be a lot of GPs out there in our listening group who maybe haven't had much experience with the use of melatonin in children. Can I ask you if there are any really good information sites or websites that you would refer either our listeners or perhaps their patients to get some more information that's evidence-based?
Evidence-based that is publicly available is based on the TGA recommendations as far as I can see, which means that there is little information out there about what children or families other than those targeted populations are. So those families, like the ones I just told you about, who want to source melatonin and they're not one of that target population, I don't know of any place that has that information because you really can't publish it because it's not based on evidence.
Right. Jazz, any other words of advice there for people who want more information?
Yeah, look, I mean, I think that there's two places where I would say, for families, certainly the Sleep Health Foundation in Australia has some really great leaflets about melatonin. And I think sometimes that can be really helpful for people to understand, why we're using it and why it's being suggested alongside behavioral modification. And so I think that can be a really useful source of information if you're looking for things to give to parents or children themselves. There's some good stuff there on adolescent sleep as well, which can be really helpful for families to understand the changes that go on. And then I think the other thing is that, there's a lot of work going on at the moment through the Australasian Sleep Association to try and make resources available. So I would certainly recommend that GPs consider looking at the resources available there. There is a new learning management system that's going to go live fairly soon, if it hasn't already, which has got some really great resources, some of which are openly to anyone for free. And there are others which you can actually take modules and things where you pay additional for that. But certainly I think, I'd go to the sources of information that people are really working in that space, because that's where you're going to find the most up-to-date information.
Completely agree with Jazz. And I guess I agree that for those people that do want to get information, those two sites are the best because it's evidence-based and the latest information.
Thanks for that, Sarah. I'll be sure to put links to all those sites on our Health Ed website as well, so people can get to them easily and explore them if they need to. Jazz, Sarah, it's been an absolutely fascinating discussion, and I really want to thank you both for sharing your expertise and your practical tips with us all today. You take care.
Thank you very much, and thanks for the opportunity to share our information. Really appreciate it.
Yeah, thanks very much. Thanks so much.
Thank you for listening. Visit healthed.com.au to create a free account and claim CPD for podcasts like this and access a record of your learning. Subscribe to the show on Spotify or Apple Podcasts for weekly episodes on a range of clinical areas relevant to your ongoing practice.